So, Deirdre, if you don't mind, I shall make a start. And very good morning to everybody to Fab Change Day and our second session in this stream of digitally enhanced care. And it's my absolute pleasure and delight to introduce this session. And in a moment, I'm going to hand over to Deirdre Stewart, who's a Senior Director and Nursing Executive at Cerner, who's going to chair this session. And we've got some fantastic guests, or fabulous guests, I should say. Just a word on Fab Change. It's in our 7th year now, and it started off with a Twitter conversation. And it's about sharing knowledge and best practice. And we're doing that in 2 ways today. One is we're doing that online in these sessions. We've got 6 streams running. And obviously, those of you who've joined us, you've managed to find how the system works. But it's a global conference. We've got people from all over the world contributing, and we are very conscious that it is one of the busiest times in the world in healthcare. So we try to make the system as simple as possible for everybody to just get in and get out of. The really important thing is the people who've given their time to not just presenting this morning, but also to the preparation that's taken them to get here and the contribution that they're going to make. We're really excited about the shares that you're going to make. The system is being recorded. It will be published on the website in perpetuity afterwards. And I'd just like to say a very big thank you again to our guests this morning. So Deirdre, I'm going to hand over to you now to welcome your guests and to allow you to chair the session. I'll be on hand and I'll come back in towards the end.
Okay, thank you very much, Shane. That was a great introduction. I just wanted to say at the outset, the Academy of Fab Change has been followed globally. And I remember following and being very grateful really for the information that has been shared in previous years when I was in my position as Chief Nursing Officer for Cerner in the Middle East. And we used to follow that with all of our clients over there. I'm a nursing executive with Cerner here in the UK. And I am delighted to bring together a great group of panelists this morning. Who I will get to introduce themselves in the coming minutes before we dive into what they have been doing during the coronavirus pandemic, and again, how they're getting ready or how they are ready for the next wave that comes. In Cerner, we've been delighted to help dozens of our clients here in the UK to help manage through this crisis from a sort of like a digital perspective through electronic health records, our population health. The way that people have had to react and then move towards recovery and now go to sort of like reimagine how healthcare is going to be in the future, as we heard in the previous session as well, is nothing short of amazing. Who would have anticipated that we would be here in this position doing what we're doing at the Academy of Fab stuff last year when the 6th one was held. So I'm going to be joined today by Tristan Kerr from Barts in London, from Gordon Elder in Newcastle upon Tyne, Dr. Marcela Vizcaychipi. Marcela, you can kill me if I've murdered that name. Denise Smith from the Wirral, and Emma Taylor from the Wirral. So we'll just go around in that order. And if you could just start with just giving us a brief introduction to yourselves, your role and what you are doing at the moment. So I will start with you, Tristan.
Thank you. Good morning, everybody. Thanks for having me. My name is Tristan Kerr, Divisional Director here at Whips Cross for Barts Health. My role, in addition to that, is the Nursing Informatics Officer for the Whips Cross site, and I was responsible for our go live for We Connect a year ago today, actually, just short of a week. Thank you very much.
I'm Gordon. Can we go over to you?
Yeah, good morning. My name is Gordon Elder. I'm the Associate Director of Nursing and the Chief Nursing Information Officer for Newcastle Hospitals. And I'm also the Director of Nursing for the Nightingale Hospital Northeast. And we've had a very busy year.
Yes, I can imagine. Thank you very much. Marcela.
Yes, good morning. I am Marcela Vizcaychipi, consultant intensivist at Chelsea and Westminster Hospital in central London. I am the Divisional Clinical Information Officer and Research and Development Lead for Plant Care. And my job was to develop the critical care module in Cerner, deployed it, and be heavily involved at the front end over the last few months, and also in the back end with our analysts.
Thank you very much, Marcela. Denise? Have we got Denise and Emma?
You're on mute there, Denise. The top right button.
My name is Denise Smith. I'm community matron on Wirral. I sit with the community nursing teams, and part of my role is preventing hospital admission and looking after complex patients with healthcare needs. And during COVID, I was redeployed to the hospital home team.
Okay, thank you very much. I think there's a slight problem with the sound there. Emma?
Can you hear me?
Yes.
I'm Marcela. I'm a practitioner for older people. I also work for Wirral Community Trust. My role is obviously working with older people. I've been involved with helping the development of the frailty registry, which I was also about.
Okay, thank you. I think we'll try and work on your sound a little bit, but I'm going to move back to Tristan. So Tristan, just to sort of like get us started in this session, I wonder if you could tell us maybe just a little bit more about yourself and what you were focused on in the few months before coronavirus, before the pandemic took place. What were the sort of like the main priorities, and what had you been busy with up until then?
Yeah, absolutely. So as I said, we're just over a year into our WeConnect go live. So pre-COVID, I've been involved with the project right from the very beginning when we went out to Kansas to 2.5 years ago to see everything in action and kind of start to plan and design what we were going to be using for our nursing informatics here at Barts Health. Pre-COVID, we had gone live with what we called phase 1. So we were live with all of our nursing documentation, and we were busy planning for our second phase, which ironically was the critical care go live and theatres. And in addition to that, we were just about to start our EPMA go live and doctors documentation, which we were calling the physicians go live. So we were really busy embedding it, making sure that we were supporting our nurses, carrying on with training, and really kind of informing our MDTs that nursing were no longer using a paper bundle, which is what we were using in the organisation when I first started. Obviously, February, March, things changed quite dramatically, and we were needing to go in a very quick direction, which we'll, I'm sure, come on to.
And so, yeah, let's come to that announcement in March when Barts was announced as going to run the Nightingale in London, and I know that was like that was in the press worldwide. So it must have been fairly nerve-wracking to have to change the way you've worked for years in a matter of days or even hours, along with some crazy timelines to get Nightingale London up and ready. How do you feel Barts, your previous digital transformation to prepare you for that first surge of coronavirus?
Yeah, it certainly felt daunting. Not only did we have COVID, but we had an Excel center where we were going to be potentially receiving thousands of patients. But honestly speaking, if you'd asked me this last year, pre-go live, I think we would have been more apprehensive. We did not anticipate the success that we would have through the Cerner Millennium go live for nursing. So we went from paper. We've had a lot of staff here. One of the great things about Barts Health is our staff are very loyal and have been with us for many, many years. But that meant that they were very, very ingrained with using paper. And when we went to our go live, we were just absolutely astonished about the kind of the preparation was there, and the preparation was key. And I think that then transpired into our preparation for opening a Nightingale. But the nurses were ready, the teams were ready, and what we learned through the go live is preparation, conversations, communications, involvement really kind of stood us in good ground to think, okay, we've taken something, albeit very different, with our go live on once, we can do this again. And we just drew on everything that we've done through our go live. We knew that we had the trust in staff that were using it. We knew that it was effective for us, and we knew that should we need to be using that quickly in a different care setting, that we had the core basics to kind of make that go live. And indeed we did, and it kind of came through. But I really, it was pleasantly reassuring and really challenging times that actually everybody was up for it and just, excuse me, just rose to the challenge.
Excellent. Yeah, we've just heard the most fabulous stories about what was done and about your staff and everything else. Over the course of the next little while, I want to look at sort of, if you look at it like a continuum of care when it comes to our staff and our patients. So I want to focus a little bit maybe on the outpatient area here. And I know we have Gordon with us who will speak next, and Gordon can go into more details on the Nightingale Hospital, because they did one up in Newcastle as well. So I want to move, like, let's say from outpatients, what was done, through inpatients, and then over to sort of like the community health or population health aspect, which I will cover with Denise and Emma from the Wirral afterwards. So can you tell us a little bit about your outpatient services, how those had to change, and how successful that change was, and what have you kept from that as a, you know, more or less a permanent way or the future way of working?
Yeah, certainly. So like everybody, we had a very clear dictate to not bring patients that weren't requiring secondary care, inpatient care to the hospital. So we had to, again, think very differently to be how we could be managing those kind of long-term condition patients that we would know would be requiring inpatient care if they weren't receiving time with a clinician, and certainly kind of physical assessment via a screen. And I remember those early days when we were saying, okay, we're going to start seeing patients, but we're going to be seeing them virtually. And there were comments like, we don't live in rural Scotland, surely we can bring them up and it's a separate entrance. And we really had to kind of break it down into categories and say, okay, what patients could we see safely virtually? What patients could we follow up safely virtually? And there would be, of course, a small proportion of patients that we would need to bring in and see face to face. And we put those under hot clinics. To do that, we needed to be sure that we had a system that we were able to use, that everybody could access, and we could have a kind of continuation of that care right the way through from patients' inpatient stay versus coming in for a virtual or face-to-face outpatients. But then again, if they were to arrive through the A&E, that we had that kind of visibility of that care. So we had to get a lot of kit. we did. I don't think we've ever ordered as many webcams and microphones as we did in those phases, and of course the whole world practically were doing that. So we really had to start with the kit. We had to kit out our outpatients very differently to make sure that we had the infrastructure to support that. We had to train some of our clinicians, some of our kind of medical clinicians who had never done virtual appointments, and it's very different. It feels very normal now, but it was very different then. And equally, we had to prepare our patients. You know, we had to get patients to show limbs on a screen and move their limbs in a different way so that the doctors and nurses could be able to assess. So once we had that set up, we then had a very kind of robust operational support just to be able to say, okay, these are the patients that are at risk, and we categorized those to say in priorities 1, 2, and 3. And I'm really pleased to say that we've reduced our face-to-face outpatients by 70%.
70%.
70%. And through our learning, we've created, Barts Health love an acronym, and we've put a bit of strategy behind them. We've got a piece called COVOG, which stands for obviously COVID, but it's around our outpatients facilities and what we want to change and what we want to keep. And that's got a true MDT focus. That's got our system partners, that's got Barts Health, and it's got patients to say, okay, we're going to continue to do this. How do we know we're getting it right? How do we know we're seeing and treating our patients effectively? And what do we need to put in place to be able to change that? So we went from we were over seeing our patients, occupancy in outpatients was way over 100%. And I'm pleased to say last week's figures was 33%. So we're not quite, at the 70-30, but we're working really, really hard to do that. And what that means is
that's absolutely amazing. I love hearing stories like this, Tristan, but I need to go back. I always love, if I can learn a new acronym every day, then I'm a happy nurse. So did you say COVOP, as in coronavirus video outpatient?
COVOG, yeah, co-VOG.
VOD, and video, that is?
It's COVID, and then the outpatients, I'm going to have to remember it myself now. We've got COVOG, we've got COVID, we've got,
okay.
But COVID is our emergency care stream. I will find out what the G stands for.
That would be brilliant. And if you get it, once I'm talking to Gordon, you can pop it in the chat, because I'm sure everybody else is just as curious. I'll just ask one more question to you, because I'll need to move on and try and keep things on time. But you're part of sort of like the One London record. So that longitudinal sort of like patient health record, you're getting patient details from GPs, from social care, from from hospitals or whatever. What part, or how has that helped during the management of your acute patients during this COVID pandemic?
Yeah, no, absolutely. And if I'm honest, it's got stronger through this, because there was an ever more of a need, and people were working remotely, not in offices, for us to be able to ring. GPs were working differently. So it's really kind of enhanced our East London patient record. We were using it in pockets, but it's really kind of helped us to be able to plan and use that more widely. Just outside, we were using it very well within our community services, GPs, and we're now really pushing that for our nursing homes and end-of-life patients, which obviously, sadly, was even more useful during the kind of early COVID. So I think it's really helping. It's certainly helped the awareness. It's had its proof of concept proved overnight through no help of anybody, but everyone kind of saying, wow, this allows us all to see. It also allows kind of our GP partners to know when we're bringing those patients back, when we've seen them. And it's almost a live stream, because as soon as the virtual or outpatient record is created, that's then on the system, and then the GP's got sight of that, and then they know when they're coming back to hospital.
So it sounds like fabulous joined up connected care going on there from a fabulously connected team in Barts Health, yeah?
Yes, I'm very, very proud of Barts Health. I'm proud of everyone in the NHS, but Barts Health really, really did step up to the mark during this.
Absolutely. Excellent. Well, I'm going to give you a little break, Tristan, and I'm going to move straight to Gordon. I'm up with Newcastle upon Tyne. So, Gordon, can you tell us a little bit about yourself and what you were actually working on when Britain was preparing for lockdown and the COVID-19 pandemic?
Sure. So like Tristan, a year ago, almost this weekend, so it will be when the clock changed, we went live with our Paperlight program. So we had inpatient meds and orders and PAS from Cerner, as well as a few other clinical systems that we used. But we went big bang and went live with Anaesthesia, theatres and recovery, critical care, outpatient orders, meds and documentation, all clinical documentation, capacity management and referrals. So that was the 3 years of my life before that, and it accumulated. It was the most difficult thing I'd ever done up to that stage, but it was a very successful launch, and we done optimization till just after Christmas, and we were starting to do more optimization in January to February whenever COVID started to creep in.
When life changed. So in Newcastle, you've deployed a 400-bed, or in Sunderland, 400-bed Nightingale Hospital. Now, I know, again, it was on very short notice, but tell us a little bit about the role, I would say the role of the informatics department in making sure that what you were doing in the Nightingale Hospital was going to be, you know, it was going to be usable, adoptable, and, you know, and suited the situation.
Sorry, Deirdre, you just broke up at the end there.
Yeah, so your experience, can you talk a little bit about the role of nursing informatics, or of informatics, clinical informatics, in talking about the scope of what you achieved in the Nightingale Hospital?
Sure. So on Friday, the 27th of March, I got a text message from our executive chief nurse asking me would I want to be the lead for the Nightingale Hospital in the Northeast. And I said, yep, that sounds like a challenge. And on Saturday morning at 7:30, I was in an empty warehouse designing wards, and had workmen lying out on a concrete floor to decide where we were going to put beds and how we were going to map this out. The question of us being fully digital was never really in question. So myself as the lead nurse, the lead project manager was our program director for our Paperlite program. And one of my senior nurses was one of our clinical informatics nurses. So from the onset, we were absolutely determined that Nightingale Northeast would be fully digital, because we'd also heard from from Italy and Spain, and we got a lot of help from London Nightingale in the Excel Centre, saying that the paper was a problem because once it went into the unit, it became contaminated. Therefore, it had to be put away and bagged and left for a while before you could touch it again. So we were determined that we would go for fully digital. Sorry, Deirdre, I can't hear you.
You're on mute, Deirdre.
Let me apologize. My dogs were barking, so I had to go on mute for a minute. Gordon, did you run into any unexpected issues with the deployment of the system or the equipment in your Nightingale Hospital?
Well, I think because it was fresh in our minds, and we literally done a 3-year project and deployed it across one of the largest teaching trusts in the country, we were well up for it. But we did run across a few things, and we only ended up with 3 pieces of paper out of the entire hospital. One was ECGs, because we couldn't get our hands on electronic ECG to feed directly into the electronic system. The second one was controlled drugs, because we require signing out from pharmacy needs a wet signature. And the third one was the observations chart at the end of the beds in ITU. And the reason for that was we planned to put BMDI in so that we would connect ventilators and monitors directly into the system as we do within the trust. Unfortunately, the ventilators that they sent us had Windows 3.1 on them. So there was no way that we were integrating them into the system. So we had to go back to paper charts for ventilator settings only. The monitors were fine and we integrated those, but we couldn't integrate the ventilator.
So has that been resolved since?
Yes. So our new stock of ventilators have arrived. We've got 50 of them, and they are all compatible. So the work's actually ongoing at the minute to connect all of those up. They only arrived about 2 weeks ago.
Excellent. Well, please God, you won't have to use all 50 of them. And if we control this, I hope you won't have to use that many of them at all. You brought up a very good point there about the controlled drugs, especially needing a wet signature on that. So, you know, that's probably a good area to focus on for the future, because, you know, there is, I can't think of much reason for that to say it has to remain on paper with a wet signature. I know I've worked where regulations have been updated and that has been removed so that the actual electronic signature and double signature serves as the legal document as well. Have you found that as a common thread around the place? Do you have, you know?
So we fed that back up through the Nightingale national structure because we weren't the only ones that found that. And it does have to be changed. But it's a change in legislation, it's a change in the law to do that. And we must do that. And we're still pushing for that to be done in relation to, because we want to be able to do that across the entire trust as well.
Okay. I believe you had some lessons learned on the amount of data that needs to be captured on sick patients by incredibly hard-working teams with high workloads. Would you like to share anything around what you found about, you know, what needs to be captured and how it's used?
Yeah. So we were, like all the other Nightingales, we would be pulling staff, nursing staff and medical staff and AHPs from across the region. So nursing staff especially were by far the biggest number. If they were coming from Newcastle, they already knew how to use our system. I was very concerned that we were pulling nurses across from multiple trusts across the region who would never seen our system before. So there's a number of safeguards that we put in, electronic observations on iPods. So each nurse would have an iPod and they could access all of the observations there. But we also had a command center and our whiteboards are electronic. I was concerned that nurses wouldn't be able to understand the system quickly enough. So we placed 12 monitors within the command center where we could monitor each ward. So there were 12 wards and 8 intensive cares. We'd monitor each ward. So if you'd seen a deteriorating patient, or if there was anything that was stopping that ward from being functional, they slowed down, they were non-compliant with observations or whatever, then the senior nursing team would be able to go and intervene to find out, was there something wrong? Was there a staffing problem? Had they high acuity of patients? All of that stuff. So that was the safety checks that we had put in to make sure that all of any deteriorating patient alerts would immediately be seen by the senior team. We also stripped back considerably our EPR. We had one login. We had only one login for whether you were doctor, nurse, AHP. It made no difference. One workflow, workflow as well. So everybody worked from the same workflow, and that would have worked incredibly well. Because we stripped back our admission documentation, all of the stuff that nursing staff collect for data collection, and you could absolutely question why we collect this. It doesn't benefit the patient, but we collect it for data collection or sequin or lots of other things. All of that stuff was removed, and we actually removed about 47% of our EPR recording for nursing and medical staff, and made it extremely streamlined, but safe. And we evaluated and risk assessed it, and it was still safe. And
so that was well adopted by your staff and appreciated. Yes. Very good. Yes. Excellent. Well, thank you very much, Gordon. I'll come back to you again if we have more time at the end. But I'd like to just pick up now with Marcela and say, Marcela, if you can just tell us a little bit about yourself and what you were working on prior to March of this year.
Okay, thank you, Deirdre, and thank you, Gordon, for sharing your experience over there as well. I think that's brilliant. If you need some extra help with control drugs, I'm very happy to put you in contact with my team, because we actually managed to get that, get fully integrated into Cerner, into our electronic medical records. We are not using any more wet signatures.
Excellent.
Oh, that's really interesting. We'll have a chat after this.
Now, yes, see, isn't that a perfect example of what this day is for, sharing the information like that? Super. Okay, Marcela.
And the last point is ventilators. I'm very happy to help you around that. I found a way to integrate our ventilators to our central monitors, and from there, the data feed straight into Cerner, instead of going directly into Cerner. But happy out of this to chat about it, because it's a straightforward piece of work to do, if you like. In regards to my work, what can I say? So firstly, thank you for inviting me to share with you and the team our experience at Chelsea. It was a busy time. As you all know by now, I am an intensivist, full-time clinician, that does the extra bit to keep a system going. So I have to be at the front line from the very beginning. We have seen more than 150 patients in the intensive care unit and more than 1,300 patients in our organization during the first surge. So it was busy, and we were in a new system because we took the electronic medical records Cerner live on the 5th of November. So we were pretty much in the optimization phase before COVID hit us. That was
this is very much the same with our speakers this morning. Yeah.
So, but I think that by being the lead of the critical care module and being in contact with the Cerner team, the Informatics team, and analyst config and IT team, you know, kind of allowed me to prepare for the worst when we were not even thinking of it. To take you through the path, back in January, by the end of January, when I came back from Argentina, I was alarmed by the cases and the information that was coming through from China. So at that point, I started discussing with my transformation team and with my analyst config how we could create a virtual intensive care. So by the end of February, my organization had basically 170 intensive care beds fully built in the system if I needed to do it, to use them. And the way that I done it is by creating a virtual intensive care. So the different areas in the hospital could be converted into an intensive care unit if that needed to be. And how I decided or picked the areas that was based on oxygen supply and air supply. That's quite important because we can build a virtual unit, but if you don't have the basics, there's not much we can deliver. So that was the first step. So, and as soon as we started getting patients through the system, one of the things I started doing was data mining straight away. So not only from the front end, I was examining patients and bringing the informatics team and letting them know about what I was seeing and what I was expecting. And in the back end, they were pulling all the physiological data and clinical data that we were inputting as a physicians. Based on that, when I have seen or examined around 20, 25 patients, straight away, we identified that was a pattern in there. Nothing new is what was reported in China, seeing more in men. We were seeing a lot of men patients coming through, young men patients, and very high D-dimer and CRP. And that was kind of, seems like we can start looking into these trends and slowly started modeling. And by patients around 70, we realized that the CRP, that is a common marker, an independent biomarker to identify patients at risk of developing thromboembolic events. And that was kind of, so that is what we need to start modeling. So what we did is, in a simple way, I created a traffic light system. That allows us at the front end to stratify patients, and the back end allowed us to actually create a dashboard that could report. So allow us to identify patients at medium risk, patients at high risk, and patients at suspected risk of developing thromboembolic events or inflammatory cytokine storm. And in a second stage, we added severe ARDS or acute respiratory failure, complicated with secondary infections. I think that tool was first tested manually, and so I did Excel spreadsheet and informed my colleagues from the front end when patients were flagging. And we defined the treatment for those patients. And then that was incorporated into a visual dashboard. It's a net base that allowed clinicians with a login and password to see how many patients were flagged as COVID positive, and at patient level, we could see the variables that were flagging and the worst, and then once treatment was introduced, how it evolved over time. So that was extraordinary because it allowed us to adjust treatment at the front end according to patients' risk, but also allowed us to monitor patients' response to the treatment and identify the consumption of oxygen, because that is another thing that I done as part of that modeling. But I can discuss about that a bit later. This model actually helped us to control or reduce or have very low mortality. I think that we got a net reduction on our mortality of 33% before and after introduction of our traffic light system. It was just incredible because people that were on shielding, for instance, or isolated, they could access the electronic medical records, see the patient was flagging as a high risk or suspected risk, and they could actually alert the colleagues at the front end and adjust treatments accordingly. I think that was a way of utilizing the clinical workforce that was at the front end, but also the ones that were at home. So we are kind of pleased about this system, and we actually published, so it's freely available in peer-reviewed journals in the EMJ, and the system identified patients from the point that they come to hospital. So imagine, you come to hospital, 10 minutes later, you will flag if you are medium, high, or suspected risk. And then that gets updated every 10 minutes. So we see the progression of our patients throughout. And then we plan what is going to happen to them at the end. So I think that was intense. I'm not going to deny because it's doing the clinical plus that component. But now we got the artificial intelligence, and that is fully embedded in our clinical practice, and we are ready for the second surge. That actually is happening.
Marcela, I didn't need to come in and ask you any questions there at all. You just you went through everything, and I think that is nothing short of, it's absolutely fabulous, but it's nothing short of amazing how you were able to harness, your knowledge of informatics, the team, your knowledge of the disease, the research and everything to pull together. And the fact that you were actually engaged from earlier, you sort of like, it was almost like your own predictive analytics was telling you we're going to need a virtual ICU very soon. So I think kudos to you and the team at Chelsea and Westminster, because that is an amazing story. Now, I know you've co-authored a paper, and that has been published, as you say, in BMJ and elsewhere. Maybe you could just pop the title of that into the chat here, so that
Okay.
others would be able to download it and read it. That was on your stratification tools and the artificial intelligence clinical decision support that went into that.
Yes, I would love to share that. Being honest, we put as a preprint on the 28th of April, was available to all on MedArchive, because we thought if it is helping us, it should help others. And our code is freely accessible, so any informatic team across the globe can actually access it and run the same algorithms in their databases and just start acting. Because in my head about this disease is what we can do to prevent progression. A lot of people are working on the vaccine, that is fabulous. There are a lot of people working on the drug that will treat the virus, fantastic. But we all working in the national health system, and we look after people that are already infected and critically unwell. You know, we need to find ways to prevent complications and manage things that can be treated. And there are more than 93 clinical papers showing in postmortems that the commonest cause of death of patients infected with COVID is thromboembolism, thrombosis, clot in the blood. So it makes sense to me that we need to identify the patients at risk and treat them throughout. And I think that helped. And I'm just monitoring, for instance, for our second surge, we have admitted 287 patients by yesterday and 27 in the intensive care unit since the 1st of September. So the numbers are going up, but our previous mortality when I done the analysis was 23%. Now, because the system is embedded, is around 14% so far. So 1-4. So clearly, this kind of integration and early management makes a big difference. And that is thanks to the electronic medical records and the analytics that we are doing behind scenes as well.
So it's true evidence of, you know, the people and the process and the technology all supporting each other.
Exactly. I think that it's all about what we as organization and as a multidisciplinary team can do to save lives. Because that's our job in acute hospitals, how we can prevent disease.
Yes.
And that's all about.
Marcela, thank you very much. That was absolutely amazing. And I'm sure you're going to be inundated with people wanting questions and more information after this. I'm going to move out. We've sort of like looked at a lot of the outpatient work with Barts and now the inpatient with Newcastle and Chelsea Westminster. We're going to now move to a sort of population health platform and look at what our colleagues in the Wirral have been doing. So I'm going to call on Denise. And if we start with you, Denise, and just tell us a little bit about yourself, what you were working on before the COVID-19 pandemic took place.
Okay, so I'm Denise, I'm a communication on the Wirral. And before the pandemic, my main job was part of an integrated care coordination team, which involves physios, social workers, nurse practitioners and the older persons, private sectors, charitable agencies like Age UK. So we have referrals from GPs, from other professionals, from the community nurses in regards to patients that have complex care needs that may need an MTC input. We'd also be involved in a lot of respiratory patients who needed, who were, you know, being admitted regularly. Our aim is to try and keep people from being admitted to hospital with complex care needs. So that was my main role before COVID.
Excellent. And Denise, I think the sound is still just a little bit distorted from your side. So we'll find out how others are thinking. So you were given the mission to make sure that the older population could be managed at home and do your best to sort of like avoid admission or readmission to hospitals, which basically meant you needed to set up a hospital at home team with a multidisciplinary team from across the community to try and maintain your older population and your at-risk population at home. Tell us a little bit about what you had to do in regards to that.
Okay, so I was put into the team to, plus a lot of stuff we really talk about, we're also including the dietitists, health visitors, other staff that are normally doing that acute role. So I got put into the team to try and upskill and train them in IV skills, venipuncture, recognising acute problems, looking at observations and acting on them, referring to the GP, referring to the geriatricians, just trying to support them in upskilling them really. So that was my main job. It was just support, clinical support, staff weren't normally doing that in that area.
All right, and how did it work? How did you? So you have your hospital at home basically up and running. Tell us a little bit about how it worked for you and your older population in the Wirral.
Okay, so what we did was as a community matron, we did a respiratory waiting list because they're the main patients that were being admitted and they were at high risk. We recognised them as high risk. So from that waiting list that we compiled with referrals from the GPs, from shielded patients, we were able to pick out vulnerable patients who would be at risk of being admitted. So because of the electronic care records, we were able to see how many hospital admissions we had, what medications they were on, because everything was updated. So we were able to act upon that. And when a referral came in from outside source, GPs, geriatricians, and nurses, we were able to look straight away at the problems, any interventions that I need. So we look at referring them to OTs, physios, put things like fall alarms, mainly hospital prevention. And when someone came in and they were quite poorly, we liaised with geriatricians and we look at that, IV antibiotics up for 3 days, monitoring subcut fluids, taking bloods, looking at the electronic health records, blood results, discussing medication changes with geriatricians and the GPs, discussing things within our own service, type of input would be best. When we even managed to, when we redeployed staff in pediatrics, we were even able to, because of social care problem and lack of social care workers in care agencies, we were able to ask pediatrists, health visitors to support care staff in just keeping people at home. They might need a short intervention, 3 day to a week intervention, a little bit of extra help to get washed dressed while they were poorly. So that prevented hospital admissions from a social care point of view. So
and you were able to drive you managed to avoid, what was it like? What percentage of admissions do you think you managed to avoid?
Out of 236 referrals, only 24 were admitted to the hospital. So we were able to keep them at home with medical care and social care support.
And these are 237 patients that would otherwise have been admitted into the hospital?
Yeah.
Out of whom only 24 actually were critical enough that you were able to manage the rest of them, over 200 patients at home who would normally have been in hospital.
Yeah. Just trying to
when I'm old, I want to move to Wirral. I want to be looked after in my own home and avoid admission to hospitals. Denise, thank you very much. I know we're sort of like we're running a little bit close on time now, so I want to bring Emma in to help finish off the story. Emma, are you there?
Yes, sorry, yeah, coming back.
It's beautiful, the hot chairs in the Wirral for community health. So Emma, the next part of this, or the final part of this, is you developed this model, you managed it extremely successfully. How does it go forward? I believe you're developing like a frailty dashboard. Can you tell us a little bit about the frailty dashboard and how the the health information exchange or the longitudinal health record has helped you in your work?
I mean, that's been absolutely vital, really, as clinicians, because we're going out to patients and we can access on our computer when the patients have had blood results done. And this is through the health information exchange that we're currently using, where we can check up on blood, discharge letters, and things like that. But the use of the new blood Kerr record, which is going to be used, is actually going to be much better, because through that we're creating dashboards. So there'll be a COPD one, but the one that we're really focusing on now is the frailty dashboard. So from that, the data is input. It is read-only, but the data comes through from the Wirral Community Trust, data comes through from the hospital, comes through from the social services, through the CCG. So all this information is input overnight and then updated, so we can see things like if patients who are severely frail, whether or not they've actually had their comprehensive geriatric assessment, have they had the medication review, have they had a full assessment, a carers assessment, advanced care planning. So through the dashboard, it's got little little tablets, and if it's not been done, it shows it in red. If it's been done, it's green. So through this, it will hopefully reduce duplication as well, because staff can go on and see what's been done and what needs to be done. It's also hoped that the use of this will improve, as Denise mentioned about our ICCT, the Integrated Care Coordination Team. When we get the patients coming through, we'll be able to actually access the dashboard and see again what needs to be done. So this will aid our clinicians when they're going out to do their visits.
And so are you ready for the next wave now? Are you staffed up again? You're going to be able to manage your frailer and at-risk patients at home?
I think we are. I mean, it works so well within the Wirral, and everyone supports each other, and that was a big thing through the primary care networks as well. We've really strengthened relationships, and we've had like joint network meetings, and we had joint training, and we've shadowed each other, so everyone's got a good idea of what everyone's doing and who to access. So we feel that through the next part, because everyone knows what everyone's doing and who to access, that will definitely improve things. So strengthening relationships has been a vital part for the Wirral, and is working absolutely brilliantly.
I love the way you say that, Emma, because really, I mean, when you look at your hospital care, your social care, your GP services, what you've done, and indeed from all our panelists today, is you have really shown how the patient or the person is at the middle of everything we do. So there's no silos, there's no factions, there's nothing like that. It's like, we have people, we need to take care of them, we need to stop them getting sicker, we need to do the best we can. How do we all hold hands surrounding the people that we're looking after? Because I mean, they're ourselves as well at the end of the day, aren't they?
Absolutely. That's it. The patient is central to everything we do here. Absolutely.
Well, thank you very much, and congratulations on the work that you have managed to do there in the Wirral. And again, I think, you know, I presume, I would hope that there would be a lot more collaboration after this, and I know I'll be tuning into other sessions today as well to see what's going on. So from a Fab Academy perspective, I'm delighted that you've all been able to join today and help to share your stories. From a Cerner perspective, I could not be prouder as a member, you know, working with you as I've ever been in my whole 15 years, you know, in Cerner, or 30 years in informatics. So fabulously well done. I'm looking at time. Apparently we've got about 6 minutes left. So I don't know, are there any questions from the audience that we need to manage? Shane, do you want to come back in on that?
Hi, Deirdre. I don't have any questions there. Jenny, can I just double check with you if you have any? I see that Marcella's kindly shared some things in the chat. Okay.
No, haven't seen any questions come through, but do let us know.
Can I
type
ask
them
a
into the chat
question?
if you'd like us to.
There's Roy.
Hi, good morning, everybody. Greetings. Can I ask a question? Very interesting session. I've been lurking in the background. I love it. You can lurk in these sessions and no one knows. You know, when you go into a session normally late, when you go into a room at a conference and you're going back, you've got a cup of coffee and your big bag of stuff, you come in late and everybody turns around and looks at you and you have to kind of shuffle to the front, and the only seat that's left is the one right at the front, and people walk their head down, don't they? They kind of creep in because you think if you walk with your head down, you're invisible. So I've been able to lurk into your session by clicking a couple of buttons. So here I am. What a great session this is. Let me ask you a kind of a more of an ethereal question, really. So much of COVID has given us a disaster, and you know, personal tragedies. We all know people who've had tragedies. But there's so much good that's come out of this as well. And, you know, I think the great trick now is going to be to respect the past and take the best of it into the future. As a supplier and a partner to the NHS, and you play a very important part, how do you see hanging on to these changes? How do you see making COVID kind of font of a fulcrum point of change and taking the best of it into the future? How do you see that from a supplier partner's perspective?
You know, Roy, it's a pleasure to speak to you in person. I've followed you for a long time on Twitter. I love your paintings that you post on Twitter, your artwork, and I've been following all your conversations recently through IHM, and even joined IHM to follow more what's going on. Yeah,
I'm going to do a Donald Trump. I'm going to come in the audience and I go,
no, there was a drive in Scotland. You know, I would have to say, you know, collaboration. So there's a couple of huge themes coming out of this. And one of them is we have to be able to share the data for research. You look at what Marcela was able to do there in Chelsea and Westminster. There's no reason that shouldn't be shareable and comparable. We recently had our Cerner Health Conference, which was virtual, and that was for everybody around the world could dial in. There was huge attendance. I would say the major theme coming out of that is going to be, you know, artificial intelligence, machine learning, open and interoperable medical records. Look at what was there in the Wirral. That example from the Wirral is a perfect example of how, you know, the patient is really in the middle of it all. So your hospital care record was connected with your community pharmacies, with your GP, with your social care, and you have a longitudinal record. I was working in the Middle East before, and I remember one of the Minister of Health at the time, one of the sheikhs, announcing that when we were starting the electronic medical record in Abu Dhabi, and he said, "I want this to be womb to tomb." And so even then they were thinking, how do we cover, let's say that, you know, I want to have kids, like even the you know, because they were doing like marital screening for things like thalassemia and that. So when you look at sort of like the amount of data you can collect from the time, you know, somebody is contemplating having a child to the time that you might actually harvest their organs, you know, in post donation, there's no reason that data should not be available, and it should be. You know, if you look at, like, traditionally it's taken over 17 years to be able to get research into practice. With artificial intelligence and with machine learning, you're not replacing clinicians, you're not replacing clinicians' brains, you're helping them. And you can turn that around so much faster. We've seen things in COVID that have resulted in changes which could be permanent in a matter of weeks. So collaboration, open, interoperable systems, and increased, you know, support of research is definitely, I think, where it's at.
I think that's a very optimistic answer, and it does give it's a kind of inspirational answer, Deirdre, if I can say, because I mean, so there are so many people that I talk to. I mean, I can't get out and about to meet the trust like I used to. I used to go to 20 hospitals a year, GP surgery. I can't do that now because I'm too old to go out. And by the time all this is finished, I'll be too old to want to go out. So I don't know, but I mean, but in the contacts I still have, very precious contacts, people are kind of slightly frightened that we're going to get the maelstrom will just wash over all this and we'll forget it. Simon Stevens opened the conference for us this morning, and I quizzed him about it. And I thought I asked him, and he is equally enthusiastic about hanging on to the debate. What he said was the individual changes don't matter as much as changing the system so that it is possible to hang on to these changes. And I thought that was quite a wise answer, actually. I like that as an answer.
Very wise. Roy, I see we're at exactly 10 o'clock.
Deirdre, you've done it absolutely amazing. Roy, it's been fantastic to have you. And I know you're the boss, but we can't run over because we've got Adam up. We've got another session.
Bye, everybody.
Nice shirt, Roy. Nice shirt. Like it.
It takes a man to wear pink. It takes a man to wear pink.
Deirdre, with us, thanks, Roy. See you in a bit. Deirdre, thank you
so much. Everybody, you have been amazing. Fabulous.
It's been an amazing hour. Great stories. Gordon, Tristan, Marcela, Emma, and Denise. Thank you so much. Great learning. And as you said, Deirdre, live in the session we were sharing. Thank you so much. This recording will be available in the future. Really appreciate your time. It's been a great audience as well. And we look forward to the next session. Thanks again.